Manjit, can you hear me?
Yes, we can hear you.
Okay, fine.
Manjit, we have started the recording. Please start the recording
Yes.
at your end as well.
Sir, we have started from our end.
Sure. Thank you.
Yeah, good afternoon, everyone. I welcome you all for the second lecture series conducting from the National Health System Resource Center in collaboration with the DSPRUD. As we all know that in India, hypertension is a leading non-communicable disease and estimated to be attributable for nearly 10% of all deaths. Most people even don't know they are suffering from hypertension. So to strengthen the primary management of hypertension from the initial level of diagnosis up to the treatment, today we are conducting the session on standard treatment guidelines on hypertension. So I welcome you all for this session. Now I welcome Dr. Jain Srivastav, Sir, Advisor, Quality and Patient Safety Division, NHSRC, to welcome the participant and brief about the aim and objectives of this session. Over to you, sir.
Thank you, Annapurna. And at the outset, I welcome our ED NHSRC, Major General Professor Atul Kotwal, who is an eminent medical educationist, public health expert, administrator, and Army veteran, who is heading our institution. And under his leadership and guidance, this series of standard treatment guideline in collaboration with Delhi Society for Promotion of Rational Use of Drug has been organized. This series started on the World Patient Safety Day, and few of you may recall those who have joined on 17th September this year, last month, that this year's the theme was medication without harm. And somewhere when we are talking about the rational use of the drugs, preventing the harms, the drugs are administered in a safe environment, and wherever these are indicated, its use and rational use, its importance cannot be overemphasized. And in that context, like the country is grappling with the multiple burden of diseases, and in that context, besides the communicable diseases, problem of antimicrobial resistance, one of the foremost challenge in NCD is hypertension. Like we know that in the country, in India, about say 60 to 65% of the deaths happens because of NCDs, and out of that, about 25 to 30% of the diseases are mortalities due to cardiovascular problem. And globally also, about 25 to 26% of the population is found to be hypertensive, and its prevalence is going to increase. And it is estimated that by the year 2025, just after 3 years, we'll have the burden to the tune of about 30% or so. I don't know, I mean, as a practitioner of the public health, whether this will be due to better detection, or those many people are going to have this problem globally. And of course, the India being second largest country in the world will have its own share. And the government of India has come out with the, operationalization of health and wellness center, which are there in the community, in the villages, and which are largely manned by CHOs. And of course, there are, in fact, the primary health center also, which are manned by usually 2 doctors or 1 doctor. So in those setup, if we have the burden of disease to this extent, it will not be possible for, peripheral practitioner to refer these cases, every case to the district hospital where are the CHCs where the secondary care gets provided. We do realize that any case of the hypertension would require initial workout, but subsequently it's monitoring and dispensation of the drugs could easily be undertaken in the primary healthcare setup. And in that context only, in fact, in the first lecture on the 17th September last year, we covered snake bite, and the talk was delivered by eminent Padma Shri, Dr. Bhaviskar. And in this series today, we have Dr. Anupam Prakash, who is Director Professor, Department of Medicine, and he's also heading Department of Accident and Emergency at Lady Hardinge Medical College and Hospital. And the idea would be that initially, initially, Dr. Sangeeta Sharma, Professor Sangeeta Sharma, who is a Professor of Neuropsychopharmacology at IBAS, to explain about the rational use of drugs, its importance, uses of the STGs, and then later on the subject matter expert will speak. Please do post your questions in the chat box, and it will be the endeavor of our team to answer each and every question. Now, without further, taking your time, I would request our ED, Major General Professor Atul Kotwal, to deliver the inaugural address, and so that we can start the session. Once again, sir, I welcome you, and I welcome all the participants and both the faculties, Dr. Anupam Prakash and Professor Sangeeta Sharma. Thank you.
Thank you, sir. Professor Jain Srivastava, sir, Advisor Quality and Patient Safety. Dr. Sangeeta, President DSPRUD and Prof and Head in EVAS. Dr. Anupam Prakash, Director Professor and Head Medicine, Lady Hardinge Medical College. All the Quality and Patient Safety team present here in the room, and also all the participants joining us online. And I'm sure it's a mix of doctors, nurses, CHOs, and even other faculties, other streams of medicine working in government as well as in private. Standard treatment guidelines, I think you all know the importance of that. A lot of efforts have been done in the past. I remember about 17, 18 years ago also, the books were made and standard treatment guidelines were prepared. Even now, various guidelines are available. It's the implementation which is challenging, and that's why I think this kind of dissemination seminars, and rather not only dissemination, rather seminars where it could be discussed. These kinds of activities are required so that everyone is on board. That why do we need to use these standard treatment guidelines? The importance of NCDs, I don't think I need to dwell upon. Advisor QPS, Dr. Jain Srivastava has already mentioned. You all also aware how the NCDs are increasing. And just to put in perspective, that now only in the health and wellness center level, at sub-center and also at the PHC level, there are new 7 packages which have been launched. And non-communicable disease is one of the major ones. And under that, there's a screening of hypertension, diabetes, and 3 common cancers which is going on. Even at all the sub-center and PHCs, and also, of course, with referral mechanism to higher centers. So the hypertension as such, if we come to that, so there's increased numbers. The prevalence has been rising over the years, but yes, when we are trying now to screen everyone above 30 years of age in the country, the numbers will increase further. Those undetected hypertensives will also definitely come into the fold. And that is where the challenge is of providing them with appropriate and effective treatment, which is also, made available to them, along with the lifestyle changes and all which are there. The wellness component has to be there. So that's why I'd be very happy if there are very CHOs or MOPHCs present here, because you would like to understand the entire gamut, that how once we screen someone, we need to make sure that appropriate management is done, provided, along with the referral linkages, and any kind of complications, before the complications only patient is referred and management is done. And hypertension is challenging because as it is known to all of us, it is not only what is people who are diagnosed. There are a lot of undiagnosed people who don't even know they have hypertension. At the same time, who know they have hypertension and they have been diagnosed, they don't take medicine, or they do not get medicine. They can't afford to purchase from outside. And so the control, how many are under control? How many are diagnosed? How many are under treatment? How many are under control? So we have an NCD portal. The older India Hypertension Control Initiative app, IHCI simple app, has now been submerged in the NCD portal. Only one is there for ease of work for the CHOs and MOPHCs and also staff nurses and ANMs, so that there's only one portal on which they have to work. All the other facilities are there of longitudinal tracking, cohort-based monitoring, and there's a decision support system linked with that. List of medicines are also there. So once you discuss all these SDGs again today, I think it will help you in your day-to-day working. And also at the same time, I would request you to give your feedback also of the currently available drugs and any kind of issues which you are facing in a chat box. Our team will make a note of that, and it will help us in our future planning too. So without further ado, I would just like to congratulate the QPS team and the DSPRUD for organizing these series of seminars, webinars on SDGs, on important topics. And this is very important, because hypertension on its own is not only a disease or entity, it is a risk factor for many others. So that's why hypertension is one of the important conditions as such to be dealt with. So I wish the large group of all the participants who have joined online to get a benefit of this. Please be interactive. Keep writing in the chat box, so that those questions can be taken up at the end. So with that, I'll stop here and wish all the best and happy learning over the duration of next 2 to 3 hours. Thank you very much.
Thank you, sir, for always supporting and guiding us in our endeavors with your deep insight and knowledge. Without your support, we are unable to conduct this lecture series. Our next resource person is Dr. Sangeeta Sharma, President of Delhi Society for Promotion of Rational Use of Drugs, and also Professor and Head of the Neuropsychopharmacology Department, Institute of Human Behavior and Allied Sciences, New Delhi. I request you, ma'am, to take a session on evidence to action standard treatment guideline. Over to you, ma'am.
Annapurna, allow screen share. Good afternoon. Good afternoon, everyone. Good afternoon, Dr. Atul Kotwal and Dr. Jayan Srivastava for conducting and introducing the topic to the participants. And you have very aptly said, how important is this topic in today's scenario for managing hypertension. And you all know that the NHSRC had taken a lead in developing standard treatment guidelines. Can you see my screen? Is it visible?
Yes, yes. It is visible.
Okay, so I think without taking much time, let me introduce this standard treatment guideline. NHSRC had done a lot of groundwork in arranging that task force, and a group of 10-11 doctors sat, and after extensive consultation, hypertension guidelines were developed. Today we will share that, and we have Dr. Anupam Prakash speaking on experiences, ground level problems and the concerns related to management of this. Before that, I want to introduce this standard treatment guideline. All of us know, attaining universal health coverage and quality healthcare for all. This has been a real challenge, although lot has been done in this direction. Especially NHSRC had been playing a lead role here in improving upon the public health system. But yet, we need to do a lot, to improve the quality of healthcare, and we can't do this without having equal access equity in healthcare. Unless we make drugs available and accessible to patients, those who are in need of these drugs, these goals cannot be achieved. And particularly, we don't, in public health system, our mandate is that whosoever comes to our health facilities must get the necessary medicines without paying for it, because it is, so, but unfortunately, many of the patients have to pay from their pocket, and this is called regressive system of financing and irrational use of drugs. If we don't use, even the essential medicines have the potential of misuse, and if we don't use them properly for an individual patient, this would add to problems in attaining this goal. And we need to be worrying about these medicines. Rational therapeutics is very, very important, because they are the lifesavers, they improve quality, but they can be dangerous too, because of the side effect profile, because if they are given in error, and of course they are expensive medicines also. So, and misuse potential, at least I am concerned about 3 classes of medicines. Antibiotic is something that we need to be really very be careful about, because of the rising AMR problem. And then PPIs, the OCID, omeprazole, pantoprazole, this group of drugs which are being used, thinking that these are harmless medicines, but they do have long-term adverse effect profile. And of course, the controlled drugs, the morphine, benzodiazepines, these need to be, we need to be careful. There are many other challenges, because the drugs are available over the counter. We have several different dosage forms available. More than 1 lakh formulations are circulating in our country here, and they have issues with the labeling part. Prescription errors happen because of this labeling issue, because the same brand name is being given to 2 different formulations. Then you have, here I have got some examples here. There are many more examples here. So brand name is the same, but the content are entirely different. And even within the, if the content are the same, the dosage or something would be different. There are 1-letter differences in the name, and the composition is entirely different. So that is why we always say, this is a case for generic. Many of us believe that the brand names are better, but because of this labeling, packaging problems, the patient is exposed to many errors, and harm happens to them. So that's why we advocate. Even NMC now advocates, they have written this, the prescription, the drug name should be written in capital letters and in generic names. And you are all aware of the lookalike, sound-alikes in parenteral dosage, but don't forget the oral dosage forms. There are many more lookalike, sound-alike pairs in OPD pharmacy, where majority of oral dosage forms are dispensed. So, I would urge you to go and identify these pairs in the outdoor department as well. Now, before we go on to the actual concept, I want to you all to make an attempt. We have a small questionnaire pre-test. This is called, though it is called a pre-test, but the aim of this questionnaire is to understand the variations that happen in prescribing. So that will help us in understanding, what is this concept and how can we improve. Annapurna, can we put the link in the chat box? Hello?
Can you hear me, ma'am?
Yes. Can you put the link in the chat box?
Sure, ma'am. Manjit, please share the link in the chat box.
Sure.
This is a small questionnaire, although we are asking for the names here, but intent is not to name anyone or this. This is because, participating in the questionnaire before the session and after the session is important, and that would require, is one of the requirement for the certificate generation. So that is why we are asking for it.
Manjit, please share it.
And Himanshi will share.
Okay.
Okay.
So they are sharing, ma'am. Just a second.
No problem. You don't have to write your names here in the chat box. This is required only for that questionnaire, quiz questionnaire. Himanshi is going to just put up, just wait a minute. She's uploading that. Himanshi?
Yes, ma'am. Just give me 5 minutes. We are sharing it. They will get it on the email या फिर उनके मोबाइल नंबर पे जिससे भी उन लोगों ने रजिस्टर किया है उन सबको प्री टेस्ट चला जाएगा.
Okay. Okay. Oh. Abhi, have you sent
Manjit,
it or do you need to wait?
Instead of there, can you share it in chat box only?
Yeah, that would have been better. Okay, till the time you are doing it, I can move on to my
Yes, yes.
presentation. Just tinkle me, when you are ready. I think-
Sure.
Yeah, please. Okay, there are huge variations in clinical practice. This happen, it is quite natural. Many a times we think because we've been doing this for many years. Sometimes we don't realize that this is not evidence based or this is not supported by the evidence. For example, I'll give you an example here. We have been using M-clocks, this fixed dose combination for many years. This is a combination of amoxicillin and clavulanic acid. Now, if you look at the pharmacokinetics of the two drugs, amoxicillin and cloxacillin is the combination. So amoxicillin, if you look at the pharmacokinetics, it is taken 3 times a day, and cloxacillin is administered 4 times a day, 6 hourly. So, but when you combine this, either you can give it 8 hourly or 6 hourly only. But when we talk about, why are we using it? Many people, give us the reason that we have been using this for many years and we have found people responding to this. But, fundamentally, we find that there is something wrong, and also there is no evidence backing this practice also. So many times this is the past practice, or there are medical myths, or, evidence-based, evidence is not there. For example, serratiopeptidase is another example, which is very commonly used, and now people are also asking for inclusion into the essential drugs list also. But there is no evidence that it clears the inflammation faster. If you think that this is a drug which clears the inflammation faster, but then we need to do this and establish this fact and prove by doing a randomized clinical control studies to be able to say. So this is there is no evidence, but the practice is there. Now, another dimension to this problem which has come is that defensive practice is there, because of this Consumer Protection Act, or somebody may complain, why am I not doing this? Many a times medicines or investigations are being asked just to be on the safer side. We haven't made any clinic diagnosis yet, but we asked for a panel of tests, investigations to and just in case something turns out to be positive, we start treating that. So, huge variation happens. Many a times we know the diagnosis is clinical, but we depend on the investigations because either we are not aware of it or there is no evidence to support this. And of course, these have, these problems have escalated. The patients have also become demanding. They ask for care, and why have we not done, many a times patients also question you. But I think we cannot generalize these statements because all patients are not same. And everything, we add investigation or a drug we add to the patients, justified or not justified, adds to the healthcare cost. And of course, irrational use of medicines is a patient safety threat. Although we don't have data, but we know, knowing our system, how are we functioning, we know the threats to the patient and the harm happening to the patient. And certainly we would not like this to happen to ourselves when we seek medical care. And of course, rising litigation is one of the main concerns, these days, particularly in the private sector. I think even the public sector need to be very careful about it, because now courts, the consumer courts, have started giving decisions against the public health facilities as well. Earlier, it was only the private sector which was coming into the ambit, but nowadays, public sector is also not untouched here. So, and also there is a lot of gap between, I think there is this form has already been circulated. Just check it in
Yes,
your, this.
ma'am, the link is shared on their email and WhatsApp
Mobile.
or yeah,
So
in
you can
SMS as well.
access, this questionnaire either from your email or on your WhatsApp. I hope you are able.
Yeah,
Can you?
that cannot be shared here in the chat box. They have to just go to their email or mobile number and they can access it.
Okay. You'll have 10 minutes to do this. Then we will proceed with the session. Hello. I hope there is no problem in doing the. You have access to the questionnaire. The questionnaire link is there in the chat box as well. If you any of you have any difficulty, you can access this here. I'm not able to submit. I think at the end there is a submit button. ये चैट बॉक्स में लिंक दिया है, आप इस लिंक को क्लिक करेंगे तो आपको क्वेश्चनर आ जाएगा, तो प्लीज फिल अप कर दीजिए। ये इसमें भाग लेना जरूरी है, क्योंकि आपको अगर सर्टिफिकेट चाहिए तो इसमें जो लोग पहले और आखिर में भरेंगे उन्हीं को सर्टिफिकेट भेजा जाएगा। अगर कोई दिक्कत है तो आप चैट बॉक्स में लिख सकते हैं।
You can submit it, ma'am. Here many participants are submitted.
Okay, so how many have submitted already?
That we need to check, ma'am. But submission तो हो रहा है.
हाँ ठीक है, that means they are able to access this. There is no problem with this. Annapurna, could you locate Dr. Anupam Prakash? He is there in the.
बात हुआ है, ma'am. I will be there by 4 o'clock.
अच्छा ठीक है. I think if you have got this, should we move on? Or we wait for another 2 to 3 minutes?
We'll wait another 2 minutes, ma'am.
Okay, okay. Unable to submit. कोई क्वेश्चन रह गया होगा, that could also be one
No,
of the.
ma'am. Actually, the link is individual. The link shared in the chat box. Everyone cannot access that link.
Okay, okay.
They have to register via
No,
email.
but I opened it. I opened it.
You will be able to open it, but you will not be able to submit it.
Okay.
Yeah. That's why the people are getting issues in there.
तो आप अपने मोबाइल फोन से करिए या ईमेल में जो लिंक है ना उसके थ्रू करिए, तभी हो पाएगा।
हाँ, जिस पे भी आपको वो लिंक आया है आपको उसी लिंक से एक्सेस करना पड़ेगा, अदरवाइज आप नहीं कर पाएंगे।
I think, how much time left? Himanshi, can you share the results? We can start the discussion. Himanshi?
It will take some time. Just give me a minute.
Okay.
With the same link we can submit, ma'am, because from our side with the same link, 2 to 3 members have submitted.
I didn't get your point.
As Himanshi said, they are unable to submit through the link which I provided from me, which has
Mhm.
given to my WhatsApp number. But the same has shared with my colleagues, but they have tried and submitted it.
No,
I think
submit वाला button gray में हुआ हुआ है उनका ना, तो may not be active.
maybe questions are not attended. All the questions are not attended by the
Yeah,
person.
that could be one reason. Because all questions are required. If you don't attempt any one of them, it will not, submit button will not become active. Himanshi, can you display the results, poll results?
Ma'am, these are not poll results. Actually, we will get it from the back end. We can just share the number with you. And
But I wanted a discussion on this, these questions, no? On responses.
ma'am, that is not possible.
Okay. Okay, let's have a discussion on this. Let me just okay, let's go. I don't have a response. Can you see my screen? This questionnaire is there.
Yes.
Okay, I don't know the responses here, but let me tell you the correct answers for these questions and the reasons for this. Which of the following statements are correct regarding management of urinary tract infections? There were 6 choices given here. This is, uncomplicated lower urinary tract infection, especially in women. If women is symptomatic, it does not require any investigation. So the first choice that you can start empirical antibiotics based on the signs and symptoms of UTI. You just need 3 days of treatment for this, and your nitrofurantoin is a good choice for a community acquired infection and in UTI. You don't need to do a urine culture for uncomplicated cystitis, if increased frequency and if burning is there, is not needed. And also in case of indwelling catheter, it is not required. Pus cells in the urine or turbidity is not an indication to start antibiotic. You may have pus cells in the urine, but there may not be any infection. So this is many people start antibiotics just based on the number of pus cells seen on the urine analysis. And you have to urine sample demonstrating more than 10 raised to power of 5 only when the number of these cells this is pus cells only. So even high number of pus cells you don't need to, but if you grow something on if you have done urine culture, you were suspecting a upper urinary tract infection, or the patient is a high risk patient, you on urine culture, if you identify a pathogen and the colony count is more than 10 raised to power 5, then only treatment with antibiotic is required. And also asymptomatic patients, although you may find these pus cells and other things on urine analysis, but if they don't have any symptoms, there is no need to start with these antibiotics here. Now, next question is about which of the following statement regarding any fever of acute onset is correct here. The choices given are: it is always a sign of infection, should be thoroughly investigated, needs empirical antibiotics. Fever is not always a sign of infection. It could be because of the other reasons also. So it could be inflammation or infections. So you don't, fever does not mean that there is an infection. So acute fever, as the question is say, just 2 to 3 days of fever does not need thorough investigation. You have to just go by the seasons, if dengue season, malaria season, or accordingly, first you have to rule out these common causes, and then if the fever is not coming down, then perhaps you need further investigation. And of course, empirical antibiotics are not needed because infection could be because of the most often it is the viral infection. And anyway, dengue, malaria, all these infections, they don't get better with antibiotics. Now, next question was bacillary dysentery and amoebic dysentery co-infections are common. Is it true or false? Both infections happening at the same time is quite rare. Most of the time it is watery diarrhea, which is viral in origin. So 90% of the time you will have watery diarrhea, which is viral. Only 10% would have either bacillary or amoebic dysentery, and the diagnosis is clinical. If it is bacillary dysentery, then you will have blood in the stool, and in amoebic dysentery there would be mucus in the stool. But both happening together is very rare. And but this is how, if you look at our prescription pattern, you will see most of the time we are writing ciprofloxacin and tinidazole together. So thereby we mean, that as if both amoebic and bacillary dysentery happen together, and that's why we are giving both these drugs. So, if at all, first of all, you don't need antibiotic for watery diarrhea. If at all you suspect that it could be bacillary or amoebic, then you have to choose one of them. Both of them together are not needed. Then there is a traveler who presented with acute onset watery foul diarrhea with low-grade fever, and it requires treatment with, the correct choice here is, ORS, of course. Mainstay of treatment in diarrhea is oral rehydration or, parenteral rehydration, depending on the degree of dehydration, but certainly rehydration is required. And since, this is a traveler, not living in that area, and the history of foul diarrhea suggests that there may be some Giardia lamblia infection here. So perhaps ORS plus tinidazole would be a good choice for this patient. But again, ciprofloxacin would be unnecessary in this patient. Then there is a case, which all types of headaches need to be investigated thoroughly. Headache is a very common presentation of many other illnesses, or it may be migraine, tension headache. These are quite common, but it could be because of many other reasons as well. So, either we, over investigate these patients, or, some of them who require urgent evaluation, they get neglected because we are not aware of the red flag signs. So, here in this, options given here, the various red flag signs have been listed. If it is a very sudden onset within few seconds or minutes, if there is a severe headache, or an adult patient who was otherwise healthy and had no history of headaches in the past, suddenly develops these severe headaches after 50 years, or there is a change pattern, person had been having headaches earlier, but suddenly the pattern has changed over the years, or severity has increased. So perhaps this patient needs to be investigated. And neurologic, anytime you find any neurological symptoms, weakness, numbness, visual changes, if you find these changes, these need to be investigated. There may be some cerebral cause to this, but certainly headaches in the first trimester are very common. This could be because of the hormonal changes, weight changes, and the other body changes, blood volume and other physiological changes taking place in the body. The headache could be a reason for manifestation of that. And very often, because of the nausea, vomiting, the intake of fluids may not be good, so dehydration could be one of the reasons. So in first trimester, you have to think about the hydration part more than the red flag signs. Yes, of course, in the third trimester and in the second trimester, it could be a manifestation of preeclampsia, or when there is a hypertension. So episodic or fluctuating headaches over time, could be migraine, so does not need to be investigated thoroughly. Then there is a very important question, I think, which all of us see in our practice. Which of the following statements hold good for prescribing iron and calcium supplements in pregnancy? Both iron and calcium are required to be given during antenatal checkup. But in my experience, I've seen many different people following different ways of giving this. Some says you can give them together, some say one at a time, some say give one thing in the morning and the other calcium at night, or some say but none of most of the people do not know the correct way of because there is a drug interaction between iron and calcium. When given together, they chelate with each other, they bind to each other, and that is how neither iron nor calcium will be absorbed from the body. And very often we blame the supply system in our health system, that the quality of the medicine supplied is not good, because the iron, the hemoglobin is not increasing, level is not increasing. I've been giving iron to the patient for so long. The basic reason is not that the quality of the medicine is bad. It is the way we are administering, because if we give them together, or if you don't space them properly, at least there should be a spacing of 1 or 2 hours apart. Either you give 1 hour before or 2 hours after giving. So unless you follow that spacing in between the doses, the drug will not be effective. And some of the people, although respond correctly, but they forget the same kind of drug interaction will happen with the milk and milk products that we take in our diet. So iron, if taken with milk or milk product, even tea for that matter, will interact and will form a chelate and will not be absorbed. So the correct option here is, it is best to space doses of iron and milk product antacid 1 to 2 hours. Sorry, calcium is missing. So both this option and this one, third option, is correct here. You need to take care of the dietary interactions as well here. And I think with this one correction, a lot of improvement can be seen clinically. Next question is about which of the following are correct for diagnosing typhoid fever. This is the season, and we are seeing that there is a rise in typhoid fever. There are number of tests now, serological tests available, blood cultures are also available, but very often we do not know the correct interpretation of these tests. The moment we see NTH and antigen 1:160 and O antigen 1:80, the treatment for enteric fever is started. But this is in endemic area, you can have this much of this is the cutoff point for those who are not living in the endemic area. But if you are living in endemic area, it has to be at least 4 times. There has to be a 4-fold increase in these titers from acute to convalescent stage by Vidal test. Then only you can say that this is a typhoid test. The slide agglutination test is very common rapid test which is available, and very often the diagnosis is made based on this rapid typhoid. Typhi-dot is a very common test. Again, these tests, the false positivity of these tests is very high, and sensitivity is only 70%. So you cannot rely on these tests for the diagnosis of typhoid fever. And blood culture may also be negative in 60% of the cases. If there is a negative blood culture, then that does not mean that it rules out typhoid. So still the patient may still have typhoid. And one more important thing is that all these tests for the typhoid fever will come positive in the second week. If you do these tests too early, after the onset of fever, within 1 week, the reliability of these tests is very low. So usually, the laboratory or the serological diagnosis positivity chances are more if done in the second week of fever. Then there is another question. A 24-year-old woman who is 9 weeks pregnant, present with hyperemesis, she is clinically dehydrated. You can start treatment IV fluid and antiemetic. Which one of the following is the most useful guide to further management of this hyperemesis? Very quickly, hyperemesis means excessive vomiting, and the patient may lose weight, or muscular, muscle loss is also there. Very quickly, the patient would be dehydrated, and electrolyte imbalance will happen, and the ketone body, ketosis may occur. So in this case, urinary ketone is the key, indicator, or you need to follow up on these ketones to see, what should be the further management in the women. Then, which of the following statements are correct for management of preterm labor? As you know, preterm labor, tocolytic therapy is used, and there is a criteria. You can use only if the cervical dilatation is more than 2, and this is used as a short-term prolongation intervention in pregnancy, because and especially when you want that fetal lung maturity to be there, you want to gain some time for transportation of this woman, or for administration of this corticosteroid for lung maturity. Otherwise, for long term, it has no role. It can just prolong pregnancy for a few days, 4, 5, maximum 7 days only. Beyond that, there is no role of preterm. So many people think that, if tocolytic therapy is continued beyond that point, it will improve the neonatal outcomes. There is no impact on this, and antibiotics are again not needed. Antibiotics are needed only when there is a rupture of membranes, and you suspect that infection will be there. Tocolytics have a role for a short duration only, and you don't need to continue these tocolytics. And even bed rest and hydration prevents preterm. It doesn't happen like that. You have to look at what are the risk factors for the preterm delivery and manage, but once it sets in, this will not help. Now, last question is about the diagnosis and management of hypertension. I think Dr. Anupam Prakash is already there. Maybe he will discuss these things in detail. But let me tell you, a single reading of high BP could be, we should not rely on a single reading because it could be a white coat hypertension, or sometimes patient it could be a masked hypertension. It is coming normal when the patient is in your office, but at home the BP may be high. So you need to have at least 2 readings in the office separated apart, and several readings at home to be able to say that this person is hypertensive, because otherwise, if we do not recognize these issues unnecessarily, we may be treating some patients with this. Of course, diet and lifestyle modifications are non-pharmacological treatment is equally important in the management of hypertension. When it is borderline stage 1, perhaps these have more role, but eventually you may need antihypertensives to treat. How we, another, why do we need to have several readings of BP? The way we check, many a times we check the method for checking BP is also wrong. Either the cuff is of not appropriate size, or it is not tied properly at an appropriate place. It is tied over the clothes, or the patient is not resting before taking BP, or you are conversing with the patient in between while taking BP. Again, this can boost up the BP, and even urinary bladder, if the bladder is full, it may boost up BP. Too tight or too loose cuff also will give you a different readings. And remember that the BP fluctuates throughout the day, so those fluctuations would be seen more if the BP is not measured correctly. And of course, isolated hypertension, accelerated hypertension, these needs to be treated with antihypertensive drugs. The last option, any antihypertensive drugs. I have seen, patient comes to you, you have diagnosed correctly hypertension, and the dose increments are made too quickly. Within 1 week, or maybe after 2 to 3 days, patient comes to you, and you find that the blood pressure is still high. Either the dose of the antihypertensive is increased, or a new drug is added. If you know the pharmacology of antihypertensive drugs, these drugs take 3 to 4 weeks to reach its peak action. So that means any increment made before that would be excessive dose, or if you add any drug before this. So you need to wait for at least 3 to 4 weeks to see the maximum peak effect of a drug. And if you still find that the BP is high, then only the dose should be increased or a new drug can be added. But at the within 1 week, when the full onset of action has not taken effect, will lead to problems later. The patient's BP might be low. You find that after some time that this patient will come to you, now is having low BP, then you have to reduce the dose or the drug here. So I think Dr. Anupam Prakash will talk about this in further details. I can continue with my presentation. Now there is another problem, clinically that we see. Can you see my PowerPoint now? I think, okay. The prescribing cascade is another problem. What happens is, either we are making too quick changes in the dose or add drugs, or we may add another drug. Many a times we start with a medicine, patient presents to you with a side effect of that, and then we add another drug to treat that side effect, and then yet another, this second drug which was added for the treatment of the adverse effect of the first drug may have its own adverse effect, yet another drug is added to the regimen. So you find that, very commonly, which we don't appreciate, is a patient is osteoarthritis patient is taking on painkillers, non-steroidal anti-inflammatory drugs, because the fluid retention is one of the side effect of these NSAIDs painkillers. The patient develops hypertension, and then you start antihypertensive drugs for this patient. So, and very often we have, in our neuropsychiatry practice, you diagnose a patient of schizophrenia, you start with antipsychotics, and Parkinsonism or extrapyramidal side effects are the known adverse effects of these antipsychotics. We put the patient on anticholinergic drugs, and this goes on. So this is how the prescribing cascade goes. We also saw one patient who had a resistant epilepsy, post encephalitis resistant epilepsy. This patient was on a lot of anti-epileptic drugs, and over the years had because of this encephalitis, he had developed some psychotic features, so he was put on antipsychotic, and then to treat that he was given trihexyphenidyl. This is an anticholinergic. And urinary retention is one of the adverse effect of this anticholinergic drug. So this young patient, 18-year-old patient, he was seen by all kinds of expert, and they were thinking of neurological bladder, and they were very the situation was very बहुत परेशान थे parents भी और doctor भी कि what to do. 18-year-old patient, urinary retention is there. So they came to me, and I just asked, let me see your prescription. And the moment I saw trihexyphenidyl in the prescription, I asked them to discontinue this drug, and that this boy is all right. So de-prescribing is equally important. We very often we prescribe medicines and we don't review them, which can be removed, or dose can be removed, and this goes on, prescribing cascade goes on. So that is why we need standard treatment guidelines to have a standard, these are systematically developed statements. The main aim is to help the practitioners to prescribe and make decisions about appropriate management. You don't have to do this evidence-based literature review. There are all kinds of reports are there on the internet today. More than 3,000 articles are uploaded on the internet every day, and it is not possible for all of us to go through all of them and synthesize what is the outcome. And during COVID times, we have seen the number of articles coming in and then refuting the other one, in the end leaving everyone confused, what is the right way of doing it. So but if you have a standard treatment guideline, how to diagnose, then assess and monitor these patients, what to be do's and don'ts. So basic aim of the standard guidelines is to, and these are time tested tools for rational use of drugs, and of course all developed countries, they had it for many years. In our country, the need is being felt increasingly, and accreditation like NQAS or NABH, these are the main key drivers here. People like me believe in the concept of standard treatment guideline, but there are many people who have these questions. They ask, no way, how can somebody tell me? I've been trained, I am a specialist for this disease, I know, and the treatment needs to be individualized, how a one treatment can fit all of them. It infringes on my right to prescribe, or maybe some people complain that there is no flexibility in the treatment part. So all of these, for all these reasons, many people don't adopt these standard treatment guidelines in their practice. In my slides, I will quickly talk about this. Many of us do recognize that there is a gap in the practice, what we know what is correct and what we practice, but still we do not adopt this. And most of us depend on the personal experience or the discussion with peers or our training part. The problem with this is, our experience may be good, may be bad, our peers may be giving us good direction, may not be good. So all these things may lead us to problems here. So the key feature of the standard treatment guidelines is that we can't provide, textbooks deal with the treatment of many diseases, but standard treatment guidelines, the main aim is to target priority conditions. And because they need to be based on local condition, what you see in your practice commonly, most of your patient load coming with, so it should be dealing with that. And the aim is to use fewest drug, jitna kam dawai use kar sakte hain utna acha hai, and use essential medicines only, because these are time tested medicines for which there is ample evidence on safety. So the effort should be, especially at the lower level, we should not venture with the new drugs because their safety profile may not be completely known. So essential drugs which have been time tested should be used, and these guidelines are made with the patient's perspective in mind. And one of the main key, concept in standard treatment guideline is that same standard for all levels is followed. When I say same standard for all levels is followed, I mean, the patients or the diagnosis does not decide, one should get a higher level treatment or the other person should not get that. It is the referral criteria, or it is the seriousness, severity of the disease which will decide the treatment. For example, if you get a mild diarrhea patient presenting at tertiary care or Lady Harding or tertiary care hospital, that does not mean that we will give IV fluid or we will give antibiotics. Because patient diarrhea will decide, how are we going to rehydrate this patient. But if you get a similar patient or severe patient with severe dehydration, and you need to administer IV fluids and you don't have the facility at your hospital, maybe then you need to refer. So it is the referral criteria which will decide, whether you will be able to treat. But as it is, the treatment of diarrhea will not change. I have heard people saying at a higher level that patient has come to me, I need to do something different for this. So I need to, because all these must have been tried at a lower level, I must do something different and I must prescribe antibiotic for a diarrhea case. Diarrhea, you don't need antibiotics. And further, only what you need is rehydrate this patient. So similarly, pneumonia patients, it is the severity or the worsening which will decide whether you will treat this patient at this level or not. So it is the referral criteria which changes, but the management of the disease per se does not change. So for patient, it is very important that we need to be consistent in our prescribing, because the moment we differ from each other, the patients get confused. I have heard people saying कि ORS देते हैं तो patient satisfied नहीं होता है. I need to do something different for this patient. So this is because diarrhea is a self-limiting illness, will get better in few days time, and only thing you need to do is rehydrate. But the patient may, you say ORS, you prescribe ORS as per STG, ORS was prescribed, and the patient doesn't get satisfied. He goes to Dr. B, and Dr. B says ORS se thoda na theek hota hai. I need to give you some medicines. He may change the medicines, or he may give the same medicine in a different brand name, so patient doesn't know he's getting the same medicine. Or yet another one, if the patient consults another Dr. C, and he says, oh, इन दवाइयों से कैसे ठीक होगा, आपको बोतल नहीं चढ़ाऊंगा तो ताकत नहीं आएगी, तो आपको बोतल चढ़ाना पड़ेगा. So all these three different advices for same diarrhea, which is mild diarrhea without dehydration, patient may ask for it क्योंकि उनको बार बार frequency हो रही है, तो they want to get a quick fix for this. So but because different advices coming from different people, they get confused. So that is why they are not accepting ORS as one of the solutions. हमेशा there is a vicious cycle. हर बार डायरिया हुआ, कोई दवाई गोली दी, सिप्रोफ्लॉक्स दी, टिनिडाजोल दिया, तो and self limiting है, दवाई दी, ठीक हो गया, and patient thinks this is because of the medicine that he has got. All right. तो पर अगर आप सब लोग एक जैसी भाषा बोलेंगे, एक जैसी advice देंगे, तो perhaps they will also start believing that ORS is the mainstay of therapy. So consistency amongst prescriber is very important, and the patients get most effective treatment, and the drug supply can also be improved with this, and quality of care also also improves. Now to you as a prescriber, what is the advantage? You don't have to struggle to find information, kahan se milega, kaise milega, what is the best treatment. A best treatment has been worked out for you by the experts. Only thing is that you have to make a correct diagnosis. Then you can concentrate on making a diagnosis. If your diagnosis is correct, the further treatment is given in the standard treatment guideline. You can follow and assess response and modify accordingly. Another advantage of STG is that people at a lower level of healthcare, they also get educated. Many a times referrals are made to a higher level for nothing, which for a problem which can be easily be treated at a lower level, just because they do not know they can do this at this level. Their unnecessary referrals are made. So people can be capacity building can be there, and then you can your patient load, you can project your supplies accordingly and keep sufficient stock. So standard treatment guidelines help you in standardizing treatment, raising the quality of care being provided. This is one of the criteria in NQAS checklist, inputs part. They ask you, how are you ensuring that the rational therapy is being followed? It will reduce errors, it will reduce wastage, it will improve the patient's outcome. Simple, many a times the prioritization of the treatment may be missing. You may be doing the correct treatment, but they are not used in the correct sequence. For example, in this patient, shock patient, this patient was offered this normal saline bolus, and correctly, this was prescribed correctly. But, we know in shock, ensuring patent airway breathing is a priority. So first 5 minutes should be, for the oxygen. So oxygen is the first step to be followed. Then this fluid push can be given. But many of the people respond by saying, "Pehle main history lunga, sample lunga, IV line establish karunga." All this may take some time. History leke cause of shock ascertain karne mein time lagega. IV line lagane because this is a shock patient, usme bhi time lagega. So, but we can do this safely. Agar oxygen start kar diya hai, then we can take the history, establish IV line, and start this. So prioritization is important. Then many a times the diagnosis or what to do, there are different guidelines giving you different recommendations. So you don't know what is good for you in our system, healthcare system. For example, gestational diabetes. I was doing this for Odisha. We were making standard treatment guidelines for them. They were all confused. When should the pregnancy be terminated, whether it should be terminated at all or not. The WHO guideline says 41 completed weeks. NICE guideline says 38 completed weeks that you terminate. That is a huge implication for our system, that every woman at 38, if you need to terminate, then you need that many LSCS facility, and all those things are needed. So you need to make recommendation for your own system, what is good for you. Then many a times if the diagnostic criteria is not corrected, chosen properly, it may lead to either overdiagnosis or underdiagnosis. So this criteria needs to be, again, I was in Odisha. They use different criteria for diagnosis of diabetes. So according to their criteria, they were doing the overdiagnosis of diabetes. So here again, STG will come into your way, because these are made specifically relevant to your healthcare system in your condition. So you exactly know if it is given in the standard treatment guideline. For example, hypertension, if you know the correct cutoff points, then you know this is a hypertensive patient, this is pre-hypertension, or this is non-hypertensive. So that criteria also needs to be followed. And STG helps you in giving the definitive directions. Even in the textbook, I write textbooks also. So they say give slowly, or give rapid bolus should be given. But many of us, including the nurses, are confused. What do you mean by slowly? Given over 5 minutes, 10 minutes, 1 hour, 3 hours? Or what do you mean by a bolus? What do you mean by a push? So all these things are given, clarified in the standard treatment guidelines. And of course, many of you are here from the supply chain, looking after the quality. So you can measure the quality of healthcare only if you have a yardstick with you. So if you want to know whether the prescriptions are right or rational in your health facility, this can be done only if you have a yardstick. You know what is the right way of doing it. So standard treatment guidelines provide you, then you can measure whether these is being compliant with it or not compliant with it. So the STG are disease-oriented manuals, begin with the diagnosis. All you have to do is the diagnosis should be correct, and it reflects on the evidence-based, best available evidence, and the consensus for the choice of therapy. So, and as the name suggests, these are guidelines only. These are not mandatory, but following a guideline will protect you. It offers you a protection. It is necessary to follow a protocol. You should have sufficient reasons for not following a standard treatment guideline. Otherwise, you can get into a problem, because these now exist. There may be differences of opinion, there may be differences of degree of skill or standard of care, but the dictum here is that you are expected to follow an average person. You are not expected expected to be a genius here, but a average person, what standard of care should be followed. Every time, anytime, people will ask you whether the standard of care was followed or not. So standard treatment guidelines will protect you. So, and we don't expect people to have a expertise or specialization in that. A generalist view, average person, what a average person would do is expected from us. So non-adherence can get into, if you many times these may not be applicable, but then you should have reasons why a standard of care was not given to this. And presumptive approach is also not good. Courts are no longer sympathetic with public health systems. They are giving decisions against the doctors, and the compensations is being, in this 1.4 crore compensation was slabbed for missing retinopathy in a premature neonate. There were various reasons, but follow-up should have been there. Standardized care should be followed. Unnecessary prescriptions should not be given. So standard treatment guidelines, offer you, Annapurna, you can put it in the chat box, the hypertension guidelines that NHSRC has made in the chat box. So we made this, and that, NHSRC made 12 guidelines, but, in practice, we see many more diseases, people with many more diseases. So this is standard treatment guidelines, which was made by DSPRUD, is in the 6th edition. This is a kind of ready reckoner. It deals with the treatment right from the first aid, from primary care level to secondary and tertiary care level. How would you step up treatment? One problem again in clinical practice that I have seen is that we are very good at stepping up treatment. For example, in asthma, patient was not responding, you keep adding drugs, but once the patient is stabilized, he's improving, we don't make any effort to step down. We need to remove, the drugs which were added last, once the patient is stable, to reduce the number of drugs prescribed to the patient. So one of the key feature of the standard treatment guideline is that it gives step up treatment and step down. How will you step down? And it differentiates between a combination treatment and step up. Many of us, mix these two issues. Step up is, step by step, you see the response and you keep adding drugs to this, or you increase the dose. But whereas in combination, you right from the beginning, you start with the two drugs or 3 drugs as a combination. Many of us think that eventually we step up to karna hi hai, so why not add this right in the beginning? So STG would differentiate between these things. I think in hypertension, this is one of the concern. Should you start with a single drug or you start with the combination drug? How often should you make changes in the dosage regimen? So, the STG will provide you the salient features. Here include the diagnostic signs and symptoms, which will help you in diagnosis, and also the diagnostic investigations. Like there is a misuse potential for the medicine. Similarly, there is a misuse potential for the investigation. Many a times there are a lot of investigations are available. Some are banned or they don't have a good sensitivity or specificity, but we still may be asking, one of the example is typhoid dot and all those things. So the STG also provide you information on which investigation would be diagnostic, and no treatment would be complete without medicines. But of course, non-drug treatment is equally important. You're treating a diabetic patient, but he's not controlling his diet, he's not exercising, it's not going to help you. So, an assessment of response to therapy is very important. Many of the time we don't know, we start the treatment, we go ask for an investigation, we start the treatment. I think I'll be finishing, it's getting late here because Dr. Anupam Prakash will be talking to you about in detail. I think we can close these gaps with the STG. You can reduce variation, you can improve safety, quality improvement, and it would be easier for you to get this. I think I'll end this here. We have Dr. Anupam Prakash here. I think today there was some glitches, in the quiz part, so we got delayed. Sorry, Dr. Anupam Prakash. Can you just take on from here?
Good afternoon. Good afternoon, everybody. Good afternoon, madam.
Hanji, good afternoon. Thank you for
I
coming in.
understand, yes, you have a very big passion for standard treatment guidelines, and yes, you can keep on going on and on and on because it is such a mammoth task. I just saw your book also, which is a very big and a good venture. So I have a very small and task. My task is very much cut out. So I am not going to the details of hypertension per se, but I will actually, I am just sharing my screen. So what are the concerns? So, madam, you will have to stop screening. Somebody
I
else will
think
have to
I've
stop
already
screen
Okay,
sharing. Then
Ravi,
only I will be able to
yes,
screen
sir, from
share.
our side, we need to introduce you
There
to
is no
a
need to
participant.
introduce. It is okay. Perfectly fine. We will
Okay,
go
sir.
on with the presentation. I think
So,
that is
sir, I
more
welcome you.
important than. Well, thank you. So I will straightway start with the presentation because hypertension guidelines, I went through the guidelines that madam's book, Standard Treatment Guidelines have, and they are very exhaustive. And yes, they are quite practical. And I think everyone should go through them. The task that is given to me is management of hypertension experiences and concerns. So I will concentrate on the experiences and concerns part. So whatever experience we have had while dealing with patients, whether in a tertiary care hospital or when we sit in the outpatients and in public camps, I will just like to go case by case and get through the gist of hypertension. So this is a small fact check that we have why actually we need to treat hypertension or diagnose hypertension. So the important thing is that hypertension, high blood pressure, that is what we actually all call, and that is what the common persons know hypertension to be. So it is an asymptomatic disease. That means patients will not come to you with symptoms. That is what madam has also written in the text, malaise and headache and all those things may be there. But it is not necessary that the patient will have clear-cut symptoms depicting hypertension. So you have to have suspicion. You should check blood pressure for each and every patient who comes to you because the symptoms may be non-specific. Any patient who has come to you with maybe bleeding piles, you check his blood pressure, the blood pressure may be high. So unless and until you check it will not be diagnosed. Number two, it is very important. If you get the people today want to get investigations done, they will get echocardiography done, they will get chest x-ray done, they will get ultrasound done, they will get MRI and CT done. Mind you, high blood pressure requires BP apparatus and you will have to actually measure it. Diabetes can be detected on a blood report. Blood pressure cannot be. So that is very, very important. That is the importance that we need to know. Number one, it is asymptomatic and it will not be diagnosed. Number two, as long as you take the effort to measure the blood pressure. And as madam was saying, single blood pressure reading may not always be true. So you repeat it after maybe a gap of 5 minutes or maybe in the next sitting if it is not too high on the first go. The other thing that I have mentioned is rule of halves. So this is again very important. We should understand that only half of the hypertensions that exist, they are actually diagnosed. So 50% will remain undiagnosed. Half of them who are diagnosed, actually, only half of them are on treatment. So 50% of those who know that they are hypertension plus, but they will not be taking treatment. And the irony is 50% of those who are actually taking treatment, only 50% of them are actually controlled. So mind you, if we have 100 participants today who are having hypertension, 50% are undiagnosed. Of the 50% who are diagnosed, only 50% are taking medications. And another 50% of them are only taking they are achieving control even after taking medications. So only 12.5% of the total hypertension population is actually under control. So this is very, very important. We need to have a very high index of suspicion, and we should manage blood pressure in the right way, which I will just try to illuminate whatever the circumstances be. Now, this rule of 3/4 is what actually the target is for us, but we are far away from the we are actually having. So we want that rather than 50%, we should know 75% hypertension should be diagnosed. 75% of them should be taking treatment, and 75% should have actually good control. So that is what we want, but we are far away from this rule of 3/4. The other thing is hypertension. If you can control hypertension and if the blood pressures are within normal limits 24 hours a day, 365 days a year, the target organ damage does not occur. But if it is undiagnosed, it was asymptomatic, we didn't get it checked, we did not also bother to check it, then definitely anything could go wrong in the body, whether brain, stroke or CV or TIA, eyes, hemorrhage, retinal detachment, blindness, heart and the coronaries. You can have left ventricular hypertrophy, you can have heart failure, you can have coronary artery disease, you can have aortic dissection and peripheral vascular disease, and obviously acute or chronic kidney disease or rapidly progressive renal failure, what we call malignant hypertension also in these patients. So these are things. That is why target organ damage is the worrisome aspect that we all face. It is not hypertension. Yes, asymptomatic hypertension will not cause anything, but in the long run or acute decompensation, these things will be a problem. The other thing is, if you have hypertension, then you should rule out comorbidities. Like diabetes and hypertension are sisters. They stay together most of the times, especially if you have obesity also with you. So important comorbidities are diabetes, dyslipidemia, and obesity, which actually we all need to be aware of. And any hypertension should be also screened for these things also. These are important. So with this setting, we will proceed to a case. This is a very simple case. I have tried to have very simple cases for our practice. 45-year-old male comes for a routine BP check. Blood pressure is 130 by 80 millimeter of mercury. Now, by whatever the standards were earlier, was not hypertension, but now this is probably stage 1 hypertension. Because now the cutoffs are lower down, 130, 80, up between 120 to 130 systolic, and 80 to 85, you can say that yes, it is a high normal blood pressure. But anything above 130, 85 is a high blood pressure, which is stage 1 hypertension. Mind you, stage 1 hypertension. So this patient does not require treatment in the real sense. You don't need to put this patient on what you say is pharmacotherapy. But as Dr. Sangeeta was saying, it is important that you understand that this patient maybe there are so many things to check when you have a blood pressure reading measurement. So this patient should not have smoked or taken alcohol for the last half an hour. This patient should have been seated. The technique that you adopted was okay. The BP cuff should be of the optimum size. Patient was not unduly anxious. It was not that just the patient came walking to your OPD and now you have taken a blood pressure, in which case the systolic would definitely be high and we would be erring on the side of treating this patient. But yes, if all the constraints, all the precautions were taken before taking the measurement, and you repeat this BP after 5 minutes and still it is high, and you were not talking to the patient, as madam was saying, while you were measuring the blood pressure, patient was not anxious, the arm was supported, it was the level of heart, all those things, then yes, this BP is probably a red herring. You should try to counsel the patient and tell the patient he or she should actually take measures to bring it down. But pharmacotherapy at this stage can be avoided. Now, I will go a step further. This same case, BP was 130, 80 millimeter of mercury. In the evening, this BP was again measured because you sounded the patient that yes, you are having a problem. He got it measured again. And with all precautions, all standardized measures, this BP now comes out to be 134/85. So definitely this is now stage 1 hypertension. And again, I would say you don't need to treat. There are two options now. This patient, if this patient does not have any other comorbidities or does not have target organ damage, then you don't need to start pharmacotherapy. Give the patient lifestyle modification. So we will come to that in the next slide. And this patient can be given lifestyle modification for next 3 to 6 months if there are no comorbidities and there is no target organ damage. And then you can see if the patient benefits, yes, then you can continue with lifestyle modification. If no, then you at a later date, maybe 3 to 6 months later, if this BP persists, then you start pharmacotherapy. So this is another case. Same, I have not changed most of the variables because I want to keep it very, very simple. I understand you will get complex cases in n number of books, but simple cases, these are the patients who come to you in daily practice. And that is what, these are the bulk of the patients. These will be 90% of your hypertensive population. And these are the real dilemmas. So I have kept it very simplistic point of view, and I would be open to questions. You can ask me complex questions. I will try to answer them. So again, this patient has now blood pressure of 144/82. This is case 2. This is not the same patient. So this patient now is not stage 1. This is stage 2. So blood pressure is more than 140 millimeter of mercury, and diastolic, although is between 85 to 90, but that is also slightly on the higher side. So if you measure it again after 5 minutes, if it still persists, then definitely this patient does require pharmacotherapy. So stage 1 hypertension without comorbidities, without target organ damage, you can put on lifestyle management. But stage 2 hypertension, definitely you should put the patient on treatment. If this is a correct BP and you have remeasured it and this is again persisting to be high, because we do not want that this patient should actually face the brunt of high blood pressure on its target or in its vital organs. So continuing with hypertension, so 140/90 is the level which is actually without comorbidities or target organ damage. You should pharmacotherapy. So this patient has more than 140/90. So again, it is elevation in systolic blood pressure and oblique or diastolic blood pressure. So either systolic or diastolic or both. If they are elevated, then we will need to treat the patient. As I already said, 130 to 139, oblique 80 to 89, those who are stage 1 hypertension, if they have comorbidities, maybe diabetes, maybe CKD, maybe proteinuria of more than 1 gram per day, maybe comorbidity like coronary artery disease. These patients you will need to treat. So this is what is important. So this is the simplistic approach that you want to have. Now, when we talk of management, we talk of lifestyle modification. So the first thing is salt restriction. You restrict it to less than 6 gram of table salt, or in sodium terms, it is less than 2.5 gram per day. And when you ask the patient to restrict, then you give common tips like no added salt diet, or the food should be prepared with minimum of salt and there should not be any salt on the table. At least the patient should not add any salt to his or her diet. No salads, no pickles, etc. should be added there on the table. Those who want to take salt in their diet, they can put a little salt in their food. But those who are hypertensive, they should not add any salt to whatever diet has been made. And diet should be made with minimum of salt. जितना सब्जी गलाने के लिए नमक चाहिए होता है. House wives will understand that. The next step is सेंधा नमक, rock salt. Now these are all salts and they all have sodiums. They are not to be used. They are just akin to using table salt. There may be some minor differences, but yes, they all have sodium. Now there is something called low sodium salt. You should remember that this low sodium salt is not salt free or sodium free. This has sodium chloride with a bit of potassium chloride. So this still has a ratio of sodium and potassium. So this is low sodium. In fact, you will see it is LONA. LO is for low, Na is for sodium. So all these low sodium salts have sodium in them. So if you take them in excess, they are as good as table salt that you are using. So you can use them only for the purpose of slight taste. So use them minimal, and especially don't use them as a added to your whatever diet is made. Then there is something called DASH diet. This was a study diet and Mediterranean diets also for hypertension. I'm not going to the details of that, but yes, you should understand that diet rich in fruits, nuts, I'm sorry for the spelling mistake, fruits, nuts, and vegetables. So that is what is actually recommended. So you should have salads, you should take one fruit daily, you should have some green leafy vegetables also, and you should have some nuts also, maybe 10-15 grams or maybe a handful of nuts, whatever you can get hold of. That is good for your diet and for managing hypertension also. Now, these are essentials. Quit smoking, tobacco, alcohol. All forms of tobacco have to be quit. Alcohol, again, it is not advocated for hypertension. And try to meditate. Anxiety is a proponent or predisposing factor for hypertension. Similarly, yoga, regular exercise, and whatever de-stresses you, maybe music, maybe dance, maybe swimming, maybe going out in the park, sitting there for about 15 minutes. So use these de-stressing techniques. This is very, very important because hypertension, anxiety predisposes to hypertension. Those who are obese or overweight, very, very important, try to reduce weight. Even 1 kg, 2 kg, 3 kg, maybe in 6 months, 3 months will give you added advantage because it contributes to weight reduction. And those who are normal weight, they should not go for weight reduction, but yes, ensure weight maintenance. You should not gain or lose weight. That is also important. So these are management essentials which are to be advised to all patients of hypertension. Whether or not you prescribe pharmacotherapy, this has to be done. If the patient is not reducing on salt, on taking pharmacotherapy, the pharmacotherapy are valuable adjuncts. If your patients exercise daily, meditate or do yoga or de-stress, then definitely you are going to be benefited. Now this is the third case, again simplistic, 45-year-old male, 150 by 100 millimeter mercury. So this is stage 2 hypertension. Now, because this is not that between 90 to 99 millimeter of mercury diastolic. So this patient is stage 2 hypertension. Mind you, when you have a high blood pressure like this, then even number 1, I already said lifestyle modification. Number 2, pharmacotherapy. Now, in a patient who has a stage 2 hypertension, probably you will need to give 2 drugs. It is not simple process. You may not be benefiting the patient by adding a single drug. So 2 drugs may have to be started at the outset, especially if the patient has comorbidities and oblique or target organ damage. So these are important things. That is why I have made the cases very simple, minimum of verbiage, and trying to give you the points which you have. So when you think of pharmacotherapy, this is the ABCD of pharmacotherapy, A, B, C, and D. So A stands for ACE inhibitors or ARBs, B for beta blockers, C, CCBs, calcium channel blockers, D, diuretics, thiazides. Now these are the 5 frontline agents. Of recently, the beta blockers are no longer considered as first line therapy and they are not supposed to be used unless until there is a compelling indication. So you have A, C, and D. Now remember, when you have a combination to be given, then you can combine A or B, ORB, with C, ORD. So A and B should not be combined together. C and B preferably should not be combined together. This is what is the recommendation. But at times when you give triple drug therapy, you have no other choices. You know you will need to give. So ACE inhibitors and ARBs you should not combine. Beta blockers you should give only if there is a compelling indication. I will come to that a little later. So you can give a combination of ACE inhibitors and CCBs. You can give a combination of ACE inhibitors and diuretics. You can also give a combination of ACE inhibitors, CCBs, and diuretics, thiazide diuretics. The usual recommendation. And A and B are considered to be more effective in younger population, less than 55 years, and non-blacks. C and D for older populations. So those who have isolated systolic hypertension, you will like to give CCBs or diuretics. And those who have you need to give combinations, as in the case that I just showed. You will need to combine with CCB and ACE inhibitor or ACE inhibitor with diuretic. Now this is another case, 55-year-old male, recent MI and high blood pressure. So the previous case was also around about 45 years old age with a high blood pressure. but this is an added entity, added comorbidity, recent MI. So recent MI becomes a compelling indication because now you will use an antihypertensive drug which actually should cater to MI also. Similarly, if this patient was diabetes would also become a compelling indication because diabetes would compel you to use in added a particular antihypertensive drug. So I will come to this. Now, similarly, this is another case, 55-year-old male, blood pressure high and persistent AF. So here, 55-year-old male, hypertensive, yes, you can go with whatever criteria you have. But because of persistent AF, this is a compelling indication. You will use an antihypertensive which will cater to persistent AF also, atrial fibrillation. So this is how actually the log goals or the management you progress from grade 1, stage 2, with or without target organ damage, then in the presence of a comorbidity or a compelling indication. So these are the compelling indications, like a patient who has coronary artery disease, a patient who has an acute coronary syndrome, like I said, recent MI. So in those patients, you will like to give ACE inhibitors or ARBs and a beta blocker. Similarly, arrhythmias, especially tachyarrhythmias. In those patients, you will like to give a beta blocker and a calcium channel blocker because they reduce the heart rate also. Patients who have fluid overload. So you need to give diuretics and ACE inhibitors because they are the drugs which are beneficial. Similarly, anxiety states. So you give a beta blocker which reduces anxiety. Diabetes, I already said. So any patient who is diabetic as well as hypertensive, the first drug of choice for antihypertensive to be used is ACE inhibitor or an ARB or angiotensin receptor blocker. Similarly, patient who has LVH, so you will use an antihypertensive which will regress LVH. So ACE inhibitors, ARBs or calcium channel blocker. Elderly, I already said, you use C or D, calcium channel blocker or diuretics or a combination. Those who have prostatic high enlargement, use alpha blockers. So these are compelling indications which we should consider when we are treating. Similarly, when we have indications, we will have contraindications also. So this is also important. So this case 6, you have 40-year-old male, chronic smoker, high blood pressure, and you have an audible wheeze. So now, yes, chronic smoker, we want that this patient should quit smoking because he is hypertensive with his smoking and he has an audible wheeze. So this is probably a relative contraindication for some drugs. So important contraindications I have just mentioned: COAD, chronic obstructive airway disease or pulmonary disease, and asthma and diabetes. These are relative contraindications for use of beta blockers. If you have volume contraction states, that means you have intravascular volume which is low, then again, ACE inhibitors, ARBs, and diuretics are not to be used. Orthostatic hypotension, so you don't use vasodilators. So you don't use calcium channel blockers or alpha blockers. Similarly, hyponatremia, gout, diabetes, you don't use thiazide diuretics. Thiazides are known to actually precipitate diabetes mellitus, or they have increased propensity to cause diabetes in the long run. Hyperkalemia, so ACE inhibitors, ARBs, which have the propensity to cause hyperkalemia, and spironolactone, potassium sparing diuretics, you will avoid. So these are just some contraindications. So this is case 7. Again, a 55-year-old male. This is probably the last leg of my slide set. 170 by 110 millimeter of mercury. And this patient presents to you with anasarca with early morning facial puffiness. So now this patient has severe hypertension. And on the top of it, this patient has edema also, with a characteristic like early morning facial puffiness, which we all understand that it is suggestive of renal involvement. So such a high blood pressure with anasarca and probably indicates that there is some other etiology also. Now this is a 55-year-old male. So you should think of, it is not simple plain hypertension. It may be a secondary hypertension. So when you should suspect secondary hypertension is age of onset less than 30 years. So extremes of age, not the usual 30 to 55 year of age population. Then patients who present to you with accelerated hypertension or malignant hypertension, you face difficulty in controlling BP. Recurrent BP surges are there. Episodic hypertension may be seen with pheochromocytoma, even in patients who have heart failure. Resistant hypertension. So you are using 3 drugs, of which one is a diuretic, and the BP is still not controlled. Obesity or obstructive sleep apnea symptoms, again, these can contribute to secondary hypertension. And at times you will have presence of atypical features like abrupt onset of blood pressure, or a BP which is controlled suddenly becomes out of control. Electrolyte abnormalities like hyperkalemia, as could be seen in the last case, maybe CKD, chronic kidney disease patients may have hyperkalemia, at times hypokalemia, and at times atypical fat distribution like Cushing's. So these could be indicators of secondary hypertension. So in this patient, it could be chronic kidney disease, and this blood pressure, high blood pressure could be a manifestation of chronic kidney disease. Because you have anasarca, morning facial puffiness, that means this patient has renal involvement. And such a high blood pressure, you should definitely rule out. Do a dipstick, urine routine microscope. If it is positive of proteins, this patient probably has CKD. So very important. So these are the things which actually we need to think. I think that is probably the end of my slide set. And I have tried to cover through these stages, going from asymptomatic, stage 1, 2, 3, and trying to reach to secondary hypertension, covering all the aspects that Madam here, Dr. Sangeeta, has covered in her STG guidelines also. So the house is open for discussion. Any queries, any comments would be welcome. And Madam, you are requested to take forward.
Thank you, Dr. Anupam, for a very lucid presentation. It's a very big topic, actually, and to summarize it in a easily assimilated way, that shows the expertise. You made it so simple for them. There are few questions. Yeah, no, that's what is the experience. Those experts make it simple. जो थोड़ा थोड़ा जानते हैं वो complicated बना लेते हैं.
It is a very difficult topic, but if you go step by step, I think it should be easier. I understand it may be we are on the other side of the table, you and me, so we will find it very easy. But those who are listening, I hope they have been able to understand some things out of it.
There are few questions in the question and Q&A. Maybe you can also see that there is one question about how ambulatory.
My slides, I will have a look at.
आप stop कर दीजिए इसको. Now we can have a look at you also. Missing face to face. How ambulatory BP monitoring can be done at periphery, especially for borderline labile hypertension.
So the ambulatory blood pressure monitoring is good for those patients who are very anxious. Now, if you are in a peripheral setup, because the ambulatory blood pressure apparatus does cost a bit, maybe around 1 to 1.2 lakhs, 1.5 lakhs. And there is a risk that, yes, it may get spoiled if you send the patient home and the patient tampers with it. But usually it is well explained to the patient. It does not face a problem. But ambulatory blood pressure apparatus, see, we want a 24-hour control. That is number one. So that is why ambulatory blood pressure will give you 24-hour readings. Number two, the ambulatory blood pressure readings would be measured unconsciously and patient would not be, so as Madam was saying, but white collar hypertension would be averted. So these are two main things which we actually aim at. So short of that, if you don't have an ambulatory blood pressure apparatus, you can measure blood pressure, ask the patient for home BP monitoring. So at home, if the wife or son or daughter is measuring, they are measuring their own blood pressure, the patient's blood pressure also, then that anxiety component is out maybe in a couple of days. So that is one way. So you can ask the patient to measure, just like the example I gave, morning blood pressure in clinic was like this, evening blood pressure patient measured at home, still it was high. So over a couple of days, that thought block is gone, that anxiety levels go down, and you will closely mimic ambulatory blood pressure. But yes, nighttime BP recordings would remain a problem. And in that way, ambulatory blood pressure is better off. But yes, if you don't have that facility, it is going to be a problem.
Then there is a question on family history of stroke with stage 1 hypertension. Is it necessary to start pharmacotherapy? See, this is not a risk factor. Family history of a stroke is a risk factor for future stroke, not a risk factor for stage 1 hypertension. So that is not required for pharmacotherapy. So if the individual has a greater risk of hypertension or target organ damage, then definitely you will need to start. So this is not an indication. You should still give the patient, see, pharmacotherapy has its own problems. The patient can have side effects. Patient may not tolerate the drug. And once you start pharmacotherapy, that does not mean that you will obviate the non-pharmacological means. So non-pharmacological means have to be started. If they are bringing down the blood pressure, then why do you actually require pharmacotherapy?
So this is very, very important. And once you start pharmacotherapy, it has to be continued lifelong. This is very, very important. So you have to instill in the patient. And most patients, as I already said, only 12.5%, those 50% who are taking the medication, only 50% of them will achieve control. So that is the problem. So I don't say that you don't start pharmacotherapy, but this is not a case. You give lifestyle management. If the patient's blood pressure comes down to high normal values or normal values, then you don't need to actually put the patient on pharmacotherapy. I am hypertension. Individual questions are not to be allowed, but anyhow, I will take it. Treatment ethanol 50 milligram and telmisartan 40 milligram. But where I cut off said, then I immediately urged to talk. I don't get
हाँ,
it. What is the
वो
question?
उनका शायद ये कहना है कि उन्होंने जैसे हाइपरटेंशन है, उन्होंने अपनी सॉल्ट इनटेक कट कर दी, पर जैसे ही सॉल्ट इनटेक कट कर दी तो क्रेविंग सॉल्ट की होने लगी.
So these are the ideal patients where you should take Lona salt or low sodium salt. These are important patients. You supplement a small amount. See, sugar, salt, you cannot cut off from diet. They are important ingredients which the body requires to survive. And anything which you cut off suddenly, you will have a craving. So it is very, very important that you reduce. We never ask for total abstinence or total. The key word is temperate or moderation. Be temperate in your habits, and similarly be temperate in your salt intake also. Temper it down. Don't stop it all of a sudden.
Next question is about ABCD. They want you to repeat that ABCD.
A is ACE inhibitor and ARBs. B is beta blockers. C is calcium channel blockers. D is diuretics. And this you will get. These are in some guidelines. American Association of Family Physicians and probably the UK guidelines, not US guidelines. So you have to use A or B and C or D. A can be combined with C or D. That is what you have to remember. A and B is for young patients, high renin states. C and D is for elderly individuals. So calcium channel blockers and oblique or diuretics, they are intended for high blood pressure. I see some comments are there for high blood pressure in isolated systolic hypertension also. So those patients, you will give calcium channel blocker or diuretics. If you need another agent to be added, you add ACE inhibitors. Beta blockers only when actually you have a compelling indication like heart disease or arrhythmias.
There are few questions in
Yes,
chat. Emergency and urgency. They want difference between emergency. What is accelerated?
If you have a very high blood pressure, then you will need an emergent management. And these are very high, like I said, 170 by 110 or 180 by 110 blood pressure. So these have to be brought down suddenly, very rapidly. If you have associated pulmonary edema or stroke, then that means you have to bring it down further down. In cases of stroke, you have to bring down the blood pressure by 25% in the first 24 hours. 25% reduction of mean arterial pressure. And similarly for pulmonary edema, you will have to bring down the blood pressure. Don't just bring down the blood pressure to normal levels. You step down gradually. And that is what is actually important in cases of hypertensive emergencies or urgencies. If BP is under control and BP comes under 110/80, we can stop drugs. Yes, definitely you can stop drugs. But when you are stopping beta blockers or calcium channel blockers, be very careful. I would suggest to taper drugs and not stop drugs. Taper down drugs, you will come to know. And even after you stop drugs, you should continue measuring the blood pressure, maybe on every fortnight or every month, because the BP may start increasing again after a couple of months also.
Relevant, at this point, कई लोग बोलते हैं कि मुझे पता चल जाता है कि हाइपरटेंशन है ये मेरे को, तो I don't think so anyone can make out, कि मेरे को पता चल जाता है तब मैं दवाई ले लेता हूँ, या ये जो बीपी नॉर्मल की बात बता रहे हैं विद एंटी हाइपरटेंसिव, ये दवाई लेने की वजह से नॉर्मल हुआ है. If you stop it, it will come back again.
Absolutely, I totally agree. Madam has said a very valid point. So be very careful. How to manage hypertensive urgency? You can give injectable drugs rather than oral drugs. So you can give intravenous nitroprusside, nitroglycerin, and drugs like even enalapril, which are available IV, even beta blockers are available IV, and calcium channel blockers also, and mostly you will need to give them in drips so that you ensure that the BP is controlled and brought down gradually, so that your oral drugs which you give also take time to act by the time you can continue IV infusions.
There is a question in the chat box. If diastolic BP is not responding to pharmacotherapy, what should be done? Systolic is controlled, but diastolic is not controlled.
You will need to add drugs. Diastolic hypertension is not easy to control. Diastolic is important also for renal dysfunction and target organ damage. So you will need to that if you have add a diuretic. See, the second drug that you should add should always be a diuretic. It is always recommended because diuretics act very nicely. So even with ACE inhibitors, preferably add a diuretic and then add a calcium channel blocker. So they will bring down your blood pressure. Channel blockers are effective agents and it will benefit you.
There is a question about headache in hypertensive patient. Treatment for headache, because sometimes a patient is having severe headache and feels comfortable after Voveron, Perinom and Rentec injection. BP is stable and vomitings are there.
It is very difficult if your blood pressure is high, if your patient's blood pressure is high, the patient is complaining of headache, it could be number one manifestation of hypertension. So you have to bring down the blood pressure. Bringing down the blood pressure does not mean there will be immediate relief of headache. It may take a little time because whatever mediators are there, they will need to be washed out. So once you bring down the blood pressure, they will take a few more hours to come down. The other thing is, NSAIDs, you be very careful. NSAIDs cause sodium retention, sodium as well as water retention. So if you are giving NSAIDs, you be very careful, especially if you have any other comorbidity like kidney disease or heart failure, then those patients would worsen after NSAID. So be very careful when you use. You have to see what your patient is actually dealing with and what comorbidities or target organ damage is there.
I think here careful history is also required. Is it migraine, or is it really hypertension contributing to this headache? So if it is migraine, then the line of treatment would be different.
Other causes of headache would be there, and you should try to find out. See, history, as madam said, is very, very important because that will determine actually what the problem is. So the patient may be having migraine and instantly you detect the patient to be hypertensive. So it may be a tension headache also, which is contributing to both the headache as well as hypertension. You take control of hypertension, but tension headache continues. You will need to prescribe some drugs for those things. So without history, nothing works. So madam is absolutely right. Treatment for patients suffering with SVT on off. So that I said you need to give beta blockers or calcium channel blockers. That is a compelling indication. Next line of drugs to be used after A, B, C, D. Obviously, you will have to go to E, F, G, H. So you have alpha blockers. You have a whole lot of other drugs also. So you will need to add labetalol is there, alpha methyl dopa is there, hydralazine is there. You get all kinds of drugs. So you can make your own EFGH that has not been made yet.
That's a nice mnemonic, There is a question about BP raised to 150, 110 during pregnancy. What line of treatment should be given?
So that is standard guidelines for managing hypertension in pregnancy. Alpha methyl dopa and labetalol are two drugs which are very, very commonly used and very effectively used also. And you have a good amount of up titration that can be done. After that, obviously, you can use hydralazine also, which is available as a tablet formulation. And they are very effective drugs. I don't think you require after 3 drugs. There are a very minuscule proportion of patients that we find that we actually need to give any other drug after these 3 drugs.
Any antihypertensive drug which is contraindicated in acute kidney injury?
So acute kidney injury, ACE inhibitors, you should not give. The safest are calcium channel blockers and beta blockers. Diuretics only to reduce fluid overload. But otherwise, you should not give ACE inhibitors, especially if there is volume contraction. And ACE inhibitors will not act in the short term. So let the acute kidney injury part fade away and let the patient be on the path to recovery. So you will not need to give more than, and if it is an acute accelerated hypertension or what you said, hypertension urgency or emergency, then what you need to give is you will need to give nitroglycerin drip.
There is a question about, can we give an atenolol alone if BP is 156/87 and pulse rate is 117?
Atenolol alone is not recommended these days. So you use for cardio selective beta blockers. So you can use nebivolol, you can use carvedilol. So they are better drugs. Atenolol is supposed to not reduce the central aortic pressure. So it will reduce your blood pressure. It will not reduce central aortic pressure. So the damage would continue. So these days atenolol has gone into disrepute. We don't use atenolol or propranolol anymore for reducing hypertension, unless until propranolol is being used for, as madam said, migraine prophylaxis also, or treatment of migraine. So then the situation is separate. But yes, somebody has put also carvedilol can be used, and nitoprolol can be used, and you can use nebivolol. So these are bisoprolol. These are 3-4 anti-beta blockers which you can actually use.
There is a question about, can we start nitroglycerin if labetalol does not work in pregnancy-induced preeclampsia?
Labetalol, yes, labetalol can be used.
Nitroglycerin, whether
Nitroglycerin is only for if your patient is, it is not the high blood pressure, it is about the target organ damage. If the patient is going into pulmonary edema, yes. If you still want, if your patient is preeclampsia and you think the patient is going to eclampsia, you can use nitroglycerin.
There is a question about treatment for patients suffering with SIVT on and off.
That is what I said. That is probably supraventricular tachycardia that they are talking of. So yes, you can use calcium channel blockers or beta blockers with hypertension.
Then there is, can dual drug therapy be given, BD, ACE inhibitor and CCB? Clarify. I don't know question. Twice a day, I think wants to ask, when a 2-drug combination, ACE inhibitor and CCB is given, can it be given twice a day?
Yes, you can give ACE inhibitor or whatever drugs you can give twice a day. Actually, the medication, most of the drugs now available are once daily, excepting metoprolol. So most of the drugs now which are available, whether it is carvedilol, again, you can give OD or BD. In high doses, you can give BD. Otherwise, most of the drugs are now available as once daily preparation.
Then there is mild elevation of creatinine, ultrasound is normal. What drug could be started?
If there is mild elevation of creatinine, check for volume contraction, because the commonest cause of elevation of serum creatinine is prerenal azotemia. So rule out acute kidney injury. And if there is no acute kidney injury, then definitely you can add an ACE inhibitor or ARB for renal benefit.
There is a question about how to treat hypertension crisis if BP is 200 plus and diastolic is 120, if sublingual medicine is not available.
Sublingual medicine is not recommended routinely. Yes, sublingual enalapril or captopril you can use, but nifedipine is not to be used. But otherwise, what you can use is you can give IV preparations. That is what is recommended at such a high blood pressure. You can use IV enalaprilat, which is available. You can use IV metoprolol also. And otherwise, you can use nitroglycerin drips. So that is the drips that we actually use in clinical practice in our wards.
Doctor, sometimes it happens थोड़ा सा high हो गया बीच में, तो would extra dose of an anti-hypertensive drug will help this patient? Otherwise ठीक था, suddenly थोड़ा सा episode high हुआ है, तो will it help? Extra dose?
Extra dose can be given, but then you have to be very careful. You have to understand how long the duration of that drug is. So if you give 2.5 milligram of amlodipine, maybe yes, you can give, that is no harm. And the BP will need to be monitored if you give an extra dose. That is the thing that is important for us.
How do you assess response to, you started with one drug or a combination? How often would you assess the response, and when would you make decisions about either increasing the dose or adding another drug?
Antihypertensive effect takes time to act. It will take 1 week to 1.5 weeks, 7 to 10 days for their effect to stabilize. And the total effect takes about 3 weeks. So don't add a drug early. Wait for at least 3 to 4 weeks before the drugs are, you want to step up the dose or change the dose, unless until the BP is very high. So I would recommend not before 4 to 6 weeks. Give the drugs and even the lifestyle modification also. Drugs may have reached their plateau, but lifestyle modification will not reach. So unless until it is stage 2 or stage 3, it is okay. But otherwise reduce. Be patient. Be patient with your
बहुत
patients.
जल्दी इंक्रीज करने से भी प्रॉब्लम होती है.
Yes.
उसके बाद below hypotension, hypertension, normotension is the target, but अगर excessive देंगे तो hypotension, this would become an adverse effect of this. There is a question about isolated systolic BP high है पर diastolic normal है.
C or D, calcium channel blocker or diuretic for isolated diets. That is what is seen in elderly. Go for diuretics or calcium channel blocker.
There is a question है कि this is hypertension in pregnancy. Labetalol 100 milligram BD regimen is being given. Morning BP is normal, but evening BP is high. What can we give to this patient?
You will have to increase the dose, or you can give an aldomet, alpha methyl dopa.
Okay, what we can give if BP is 220 systolic and 110 diastolic after half an hour of giving diuretic?
See, you have to give, this is an hypertensive emergency, so you will need to give the patient nitroglycerin drip. You have to, don't rely upon oral medications. You start oral medications, that is okay, but you will need to give an IV drip and bring down the blood pressure. If you are don't having setup for IV drugs, then you may give 2 drugs and then wait for another 4 to 6 hours, because drugs will take time to act. So at 220, 120, you don't have time for 4 to 6 hours. So you need to give an IV medication to this patient.
What is the target BP to achieve immediately after intracerebral hemorrhage, considering perfusion in high ICT?
So cerebral autoregulation should not be altered. That is why I said you have to have 25% reduction in mean arterial pressure. So mean arterial pressure is diastolic blood pressure plus 1/3 of systolic, 1/3 of pulse pressure. So that is how you see. So 220 by 120 means 120 plus 100 by 3. That means 150 millimeter of mercury is the mean arterial pressure. Now you want to bring it by 25% of the mean arterial pressure. So somewhere around 160, 100 would be 100 plus 60 by 30, 120. So that is what is the recommended that you want actually to bring the patient down. So don't bring down the mean arterial pressure by more than 25%. Otherwise, it will result in disturbed autoregulation, cerebral autoregulation.
How do you taper down antihypertensive drugs?
But you can reduce maybe by 50% dose and observe the patient. Once if the patient's blood pressure has come to within normal range.
I think we have taken up most of the question.
It's a common topic. It does take time, I understand.
There is a question about a dental chair side management of hypertension before minor surgical procedure.
So see, this is not an emergency, but still if you need to give, the safest drug I would say is amlodipine. So you can give a slightly higher blood pressure, you give amlodipine, but don't leave the patient after that. So ask the patient to continue taking the drug, because 2.5 milligram amlodipine, today you have performed a procedure, the patient will go back home, not only for dental, but any other procedure. So this blood pressure will continue throughout. So tomorrow also, it may not be your dental chair, it may be a roadside accident or maybe something to create anxiety. The patient's blood pressure would still be high. So you still want, so you prescribe the medication to the patient, ask him to consult the doctor next day and continue with the medication and not stop it unless until the doctor tells him or her to stop.
I think there is a question about there is a major issue with calibration of automated BP apparatus, as there are no standards. Any suggestions regarding that?
No. I think there is no such major issue. Something is better than nothing is the first principle. So you have something to measure. That is important. And that standardization is for the patient himself. If today my blood pressure is 180 by 110, and if supposing it is measured in 20 millimeters extra, so still my blood pressure is high. And tomorrow it should come down to at least 20 millimeters less, 160 by 90. It may be for 20 millimeters high, it doesn't make any difference. So the reference standard is your own blood pressure. And the other thing is, if you buy a reputed BP apparatus, that those electronic measures, they are all perfectly working fine. Don't think that they are not working fine. I don't agree that it is a problem in the scenario, unless until it is probably, you should always check it with a aneroid sphygmomanometer. You can always calibrate that blood pressure. When our patients say that घर पे तो ठीक आता है, यहाँ आपके यहाँ ज़्यादा आता है, we ask them to get the BP with us, and we measure simultaneously with on the same visit with our BP apparatus and their BP apparatus. If it is working fine, we tell them it is working fine.
मुझे लगता है डॉक्टर साहब लेने का तरीका, बीपी लेने का तरीका,
Yes.
टेक्निक में बहुत वेरिएशन होती है. कई बार बहुत लूज बांधा होता है और कई बार बहुत टाइट है, या कपड़े ऊपर नहीं कर पा रहे हैं, बाजू स्लीव तो ऊपर नहीं कर पा रहे हैं, तो कपड़े के ऊपर, खासकर अभी सर्दी के दिन आएंगे तो
वो तो मैडम आपकी एसटीजी में बिल्कुल क्लियरली बड़े अच्छे से दिए हुए सारे पॉइंट्स. वो तो आदमी को देख लेना चाहिए आपके स्टैंडर्ड ट्रीटमेंट गाइडलाइंस में क्या प्रोसीजर है. दैट इज गिवन वेरी नाइसली इन योर बुक.
आई थिंक वो वाले पॉइंट पे पहले देख के फिर कोई और कारण है तो वी नीड टू लुक फॉर दैट.
डेफिनेटली.
Thank you for going through those guidelines. It gives me also confidence.
No, that is good, and that is why I covered in my slides also those things, because they are important things.
Yeah. Then BPH में hypertensive with BPH, can alpha blockers alone can do, or to add on?
Yes, alpha blockers alone. I mentioned in my case number 7 specifically, add alpha blockers, prazosin.
एक क्वेश्चन है, what drug used for frequent BP fluctuations? I think वो होना नहीं चाहिए.
Yes, then these, in such a scenario, you may split the dosing to twice a day, so that there are no peak and trough levels. And if the patient does not benefit, then you may require ambulatory blood pressure measurement.
What is the best time to take antihypertensive medicines?
See, madam, that is not defined. There are two schools of thought, but I would say we should consider that the patient should take the antihypertensive blood pressure medicine at the same point of time every day and not change. That is more important. So whether the patient takes in the morning, that is also okay. There is a school of thought which says evening would be better. That is also okay. If the patient is taking once daily medication, the timing is very important.
I think adherence to these medicines is very important.
Very right.
हम लोग भूल जाते हैं अपनी दिनचर्या में, और खासकर जब कंट्रोल हो जाता है तो थोड़ा ढीला पड़ जाते हैं.
उस टाइम याद रहे, उस टाइम मरीज से कहिए कि लेता रहे.
हाँ, एंड लिंक इट टू सम एक्टिविटी, कि ब्रेकफास्ट के बाद लेना है, डिनर के बाद लेना है, बेड टाइम के पहले लेना है, तो इट इज इजी. अगर आप जैसे भूल भी गए हैं तो वो एक्टिविटी करते ही याद आ जाता है कि हाँ आपने दवाई का टाइम है, ये लेना है. तो एडहेरेंस, मेनी टाइम्स वो बोलते हैं कि दवाई अच्छी नहीं है. दवाई से ज्यादा मुझे लगता है एडहेरेंस की प्रॉब्लम है, क्योंकि पेशेंट को भी लगता है कि ये लाइफ लॉन्ग लेना पड़ेगा, आदत तो नहीं पड़ जाएगा दवाई का. तो पेशेंट भी सवाल करता है इस बारे में. तो वन हैज टू एम्फसाइज कि ये लाइफ लॉन्ग ट्रीटमेंट है. बहुत से लोगों को तो कंटिन्यूअसली करना पड़ता है. आई थिंक सारा हो गया हमारा ना क्वेश्चंस.
चलिए, वेरी गुड मैडम.
आपको we were holding, but that means people really had these questions in mind, and I hope we have sorted out many of your queries, and it helps you in the management of hypertension. Annapurna, you can Himanshi, you can put the post test link. It must have gone to you on your mobile or on your email. Please do, आप उसको कर दीजिएगा, नहीं तो फिर आप बोलोगे कि सर्टिफिकेट नहीं मिला है. फीडबैक के लिए भी लिंक है, फीडबैक के लिए भी लिंक डाल दो. Next session would be on November 19th. Third Saturday of the month is the fixed day, and we will be taking up diabetes in the next session. We will in between take snake bite and scorpion bite again, क्योंकि उस दिन की रिकॉर्डिंग में कुछ टेक्निकल प्रॉब्लम आ गई थी. तो हम लोग रिकॉर्ड नहीं कर पाए, तो we will, and there is a lot of demand to repeat that session on snake bite and address scorpion bite. So आपको we will inform you when this session is scheduled. पर आप post test और feedback जरूर भरिएगा, तभी आपका certificate generate होगा. Meanwhile, I think all the Annapurna has already put in hypertension guidelines developed by the NHSRC, and somebody also had put up guidelines developed by ICMR. I have also put up the guidelines, made by our society. Link is there in this. You can get this. I hope all these things help you in your management, and we look forward to your continued support for future sessions. And I must thank Dr. Anupam Prakash for sparing time and addressing our participants here. It was really, I was also actively listening, and I also
Thank you, madam. Thank you so much.
Yeah, thank
And
you
thank
so
you to
much.
the audience. Thank you for being there.
Yeah, I see most of them stayed back till the end, although we overshot time, but that shows the enthusiasm, and that shows
That
the
is good.
keenness, that shows the keenness of the participants to learn on new topics.
It is
See you
good for
all.
them.
Happy Diwali to all of you.
Thank you. Same to you, everybody.
Yeah, happy Diwali, and see you on November 19th now.
Thank you, ma'am. Thank you so much from on behalf of NHSRC and also on behalf of our QPS division. And I thank to all the participants on behalf of both NHSRC and DSPRUD. I'm very much thankful to Dr. Anupam Prakash for giving the wonderful session on standard treatment guidelines on hypertension. And also I thank to Dr. Sangeeta ma'am to giving the base of the standard treatment guidelines, giving the action and also the examples of many cases. I'm thankful for you also, ma'am. And the certificate will be issued only after you have attending for the pre and post test. If it is not attended for only one test also, you won't get the certification. As it is an auto-generated certificate, you need to attend both pre and post test. And also our next session will be held on 19th of the November. The link will be shared soon from the ECHO only. And I request you to share this with your friends and colleagues so that they can also have the benefit of this STG series. I also thank to Dr. James Srivastav sir, QPS advisor, QPS division, NHSRC. And I also thank to Dr. Major General Atul Potwal, ED NHSRC on behalf of QPS division. And also I thank to all the participants attending till the end of the session. Thank you so much. The certificates will be shared within 72 hours, and YouTube link will be provided. You can access with the YouTube link within shortly. We are going to upload. Maybe by Tuesday you can access this session through the YouTube. So I thank to everyone for attending and making this session successful. Thank you, ma'am. Thank you, sir.
Annapurna, there is, some people are saying pre-test was submitted but not accepted. Could you just look into it?
Sure, ma'am. Once again, I will share the pre-test link now.
Pre-test, some of you are asking, while discussing those questions, I provided the answers to those questions. So that was already, maybe you missed that. So, go to your email or phone to access these questionnaire, and, उसको submit करेंगे, तभी आपका certificate generate होगा. I think next time, Himanshi, if you can see, we can do it in the poll form so that we can see the responses, and the participants can also listen, see what is the kind of variation in the responses.
Ma'am, we'll check with the team and we'll get back to you.
Please do get back to this.
Sure.
Yeah. I have shared the pre-test link. Who are not unable to submit, they can share with this link.
Yeah, somebody is asking, Jagriti is asking, are there more than one answers? Yes, these are multiple, checkbox are there. So if you find a round this thing, that means only one answer is there. But if you find a square in front of the question, that means more than one answer is there. So most of the questions are more than one answers. Correct. I think we were not able to mark more than one correct. There were questions जहाँ पर single correct answer था, कुछ में more than one answer था. तो आप उसमें click करते तो आपको पता चल जाता.
Yeah, I have shared pre and post test link again so that you can access it.
Himanshi, I think, okay, maybe many of them are writing that they could not click more than one. So these were check boxes in the questionnaire, not the single answer questions. So wo jo bhi banayega na, to can you share that questionnaire with me beforehand so that we know that everything is all
Next
right.
time we'll check and we'll share it with you.
Yeah, yeah.
And
Because many of them are writing that we were not able to mark more than one answers.
yes,
So-
ma'am, you can share it with me directly, or we can get on a call or something after the session.
Yeah, sure.
Okay, so I also thank to ECHO for supporting us in conducting this session. Thank you so much, ma'am. We are going to wind up now. Thank you so much.
Okay, thank you, Anpurna, for
Thank you, ma'am.
coordinating with all of us. You also need to be
It's my pleasure,
acknowledged.
ma'am.
Yeah, okay, bye. See
Bye.
you
Bye.
on
Bye.
October 19. Okay.
So, November 19th.
Sorry. November 19th.
Thank you. Thank you all.
Can we end the meeting?
Yes, ma'am.
Yes,
You can.
yes.
Okay, thank you so much for joining in.